Good afternoon and welcome to City and State's virtual Healthy New York Summit. I am Jeff Coltin, senior reporter with City and State, and I am just going to be your MC today. Going to be walking you through the next couple hours of what is hopefully our last virtual event on health in New York State and New York City. I'll leave that for some of our illustrious guests to discuss and decide on future panels, whether we can be shifting back to in-person events soon, because my gosh, it's been quite a year, but it's been so great to feel the spring coming and also feel like we're almost, hopefully almost on the other side of this COVID-19 pandemic. Look, I want to thank first of all so much our sponsors today. We've got a long list. I'm talking Health First, Metadata, T-Mobile, Brown and Weinrub, Emblem Health, Healthcare Partners IPA, Healthix, Somos, Primary Care Development Corporation, AmitaCare, CVS Health, Hinman Straub, the New York State Conference of Blue Cross Blue Shield Plans, and Ostroff Associates. So thank you so much to our sponsors for making this happen. And thank you to everybody who's joining us today. We're going to hear from some really great panelists and guests. That includes Health Commissioner Dave Chokshi, State Senator Gustavo Rivera, who's always entertaining, Ted Long, the health and hospitals expert who wowed reporters recently with his tour of the New York City vaccine bus. I don't know if any of you saw that on the local news, but if he doesn't work in healthcare, he's really got a future taking my job working in journalism. So I'm so excited to hear from all of them. And look, we want to also be hearing from you who are watching this. Please, we encourage you to be active in the chat. Just make sure to toggle it on Zoom to panelists and attendees so everybody can see. And in later panels, we'll definitely be taking questions from the audience. So please be active there, be engaged, and we'll do our best to be entertaining and engaging. And with that, I've got to hand it over to my colleague, Zach Williams, who is going to be interviewing the New York City Health Commissioner, Dave Chokshi. And, luckily that guy entered New York City's, health department at a pretty quiet time. I don't know what they're really going to talk about. It's probably, really easy transition period. So with that, over to Zach Williams.
Thanks so much, Jeff, for that very, very accurate introduction. I'm Zach Williams, staff reporter here at City and State, as well as the author for about a year of our coronavirus update email. So I'm really excited to get a chance to talk to the City Health Commissioner. So much going on with the pandemic. Just as so many people are kind of starting to think that it's in the rearview mirror, I can assure you that's far from accurate. The pandemic is certainly very much still ongoing. And I don't think there's anybody who probably better knows that than the New York City Department of Health Commissioner. So I want to just kind of give him a nice proverbial clap in lieu of our audience and welcome him to this great discussion. Thanks so much, Commissioner.
Thank you so much, Zach. I really appreciate it. And I get to lead a fantastic team at the health department. So just want to acknowledge them right here at the top.
We'll add modesty to your job description as well. So much going on with the pandemic nowadays. Yesterday featured that huge news that Johnson & Johnson's vaccine was being halted because of some safety concerns. Maybe we could just kind of start off considering how much has gone on since the pandemic began last spring. Just where are we exactly right now in New York City?
Yes, this is something that is good to orient us all. And I'll start by just building on what you had said. I'm the person who perhaps most wants the pandemic to be in the rearview mirror, but let me be clear and unequivocal that we are not there yet. So let me walk you through just some of the, the high level of where we are. First, you've probably heard me say before that data is the lifeblood of our COVID response. And I'm proud of all of the ways in which the health department has been transparent in sharing our data, in part so that all of us can be looking at the same numbers to guide us with respect to our response. Right now, we remain at relatively high levels when it comes to our percent positivity, about 5.3%. The number of cases each day, which remains between about 3,000 and 3,500, as well as hospitalizations and deaths. All of those remain at what I've been thinking of as a high plateau. We're starting to see some signs that some of those numbers are declining slightly. Perhaps most encouraging is the fact that hospitalizations, particularly for older adults, have come down in recent weeks. Since mid-January, since the peak of our second surge, hospitalizations for those older than 65 are down by 51%. Compared to 29% for those younger than 65. And although, correlation is not necessarily causation, I think the most likely explanation for that is our vaccination campaign, which has been gaining steam over that same period.
I think you hit the nail right on the head with mentioning the data. This whole pandemic has been described in terms of math, bend the curve, hospitalizations, test positivity rate, deaths obviously are the most striking number that we see every day. A lot has been made of the role of these variants in driving the so-called plateau in the numbers, where we're at least statewide staying at roughly that 4,000 hospitalization number statewide, not in the city. We've heard a lot of terms like transmissibility and this, the so-called UK variant that apparently is, 70% more transmissible. What are your thoughts on how these new variants play into the ongoing spread of the virus in the 5 boroughs?
We're in a tug of war between the variants and the vaccines. With respect to the variants, let me just break down what we know thus far. And for those who are more interested, the health department just put out an overview report summarizing our most recent data on variants just on Monday of this week, and you can find that on the health department's website. First, we've had to make strides to know that we understand the spread of variants in New York City. So the city already had a genomic surveillance approach. This is the specialized testing that we do to figure out whether or not the coronavirus is of a particular variant. Between January and now, we've really ramped up that specialized testing, that genomic surveillance, so that we're now sequencing thousands of specimens each week. The story that it has told us is that the newer variants have increased and have increased rapidly over the last several months. About 80% of all of the specimens that we're sequencing now are one of the variants of concern or variants of interest. And about 3/4 of them are just 2 variants, the B.1.1.7 or UK variant and the B.1.526 variant, which was first identified here in New York City. Now, let's not get lost in the alphabet soup. What does it all mean? What it means is that the newer versions of the coronavirus do spread more easily. And that's part of why it has been more difficult to bring the numbers down, even as vaccination proceeds. That's why it's so critically important that we don't throw caution to the wind and stay vigilant in adhering to the public health precautions that we know have worked over the last several months. And then we do have to continue to elucidate the science with respect to what I think of as the 4 key questions with the new variants. 1, are they more infectious? And the answer to that for the 2 variants that I mentioned is almost certainly yes. 2, do they cause more severe disease? And it does appear that the B.1.1.7 variant does cause more severe disease. We're not sure yet. We need to do more analysis for the B.1.526 variant. And then the 3rd and 4th questions are they more likely to cause reinfection? And are they more likely to lead to reduced effectiveness of the vaccines? And those remain unanswered questions according to the science thus far.
The science thus far, I've heard that phrase so much since the pandemic began, and it must put officials in a pretty tight spot, right? On the one hand, you're a smart guy, you're a doctor, you're the commissioner of health in New York City. You obviously know your stuff when it comes to public health, but at the same time, we're still just learning about this virus and the variants and how the vaccines work. I imagine you got to kind of feel like a party pooper at times. Everyone's getting ready for the post-COVID summer with, getting vaccinated. But at the same time, we don't even know if vaccinated people can still spread the virus. How are you striking a balance on the need to be at the risk of sounding a little, humorous, a little bit lame, but at the same time, protecting people's lives?
Yeah, well, both you and my daughter might put me in that category of being a little bit lame, but we certainly have a job to do, and part of it is in striking that right balance. I think particularly now, where we just have to acknowledge that people are tired, and not just tired, but in many cases traumatized. And that is a very real phenomenon with respect to how we as government officials, as public health leaders, have to think about our advice. And so it's something that we do take very seriously. With that said, we have a real responsibility to, do what my job is at the end of the day, which is to save as many lives as possible and prevent as much suffering as possible. And the things that have worked to do that are, at this point, not rocket science. Wearing our masks, keeping our distance, washing our hands, getting tested, and now getting vaccinated. And so we do have to continue encouraging those things so that we can get to that hoped for future as quickly as possible. Last thing that I'll say to your good question is, anyone who has really been working on our COVID response for the last year should tell you that it has been a very humbling experience, in part because of the uncertainty that we have to grapple with. And so we always do need to acknowledge that we want to give clear, simple messages that people can understand and follow. But things have changed at every turn. And so our commitment is to communicate frequently, transparently, but also to keep people updated when our own understanding changes.
One phrase that I wish had spread a lot more that probably helps public health officials is Swiss cheese. This idea that, public health is really a matter of layers, just like Swiss cheese with little holes in them. And if you wear a mask, that prevents some of the coronavirus from coming through. Get vaccinated, that stops some more. Maybe some public health restrictions here and there, hospital or restaurant capacity, for instance, and you stop more. Do you think that's the right way for people to still look at it, even after the pandemic itself is quote unquote over? Because it looks like the coronavirus is going to be around for years and years to come, right?
Yeah, well, the idea of layers of precautions working well together has been a really important one. For those of us who have been in public health and particularly working with infectious diseases, it's nothing new. When I take care of patients in the hospital, that wearing a gown, wearing a mask, washing your hands, all of these things are really important when they're done in concert. And so now the rest of the world has kind of witnessed that, and had to do that in many ways in the same way. And it's what's worked, for example, to keep our schools as safe as possible, the multiple layers of safety, the ones that you mentioned, along with increasing ventilation, making sure that we're using cohorting or pods in schools. And so, a big part of our approach has been saying that it's not, there's not any single silver bullet to take on the coronavirus. It's about all of these things working together in concert, creating a, sort of the symphony that works for public health. And I do think that just as we had to layer on additional interventions, particularly in recent months as we're taking on the variants, for example, we updated our guidance on using masks and are now encouraging people to consider using double masks or higher grade masks as ways of further curbing the spread. So, we've had to evolve our approach in that same way. In the coming months, I think we're going to start to, I hope, again, with vaccination, be able to peel back some of those layers to get closer to a semblance of normalcy. But it's not an on-off switch. It's more of a dimmer switch.
I'm kind of thinking of a metaphor as you speak, where you know, if the pandemic were a bunch of water, you know, water is not flat, right? Maybe on a quiet lake, perhaps, but not in a tumultuous city like here. And you know, while things are going to be kind of smooth for a lot of people in the city, it can still be pretty rough for a lot of communities out there. You know, we've heard so much about how equity has been a problem during the pandemic, and you know, and there's a real concern that places like, say, Brownsville, you know, neighborhoods in New York City that have been left behind in numerous ways, might still suffer, even while, you know, more well-off neighborhoods kind of put the pandemic behind them. What's kind of the status of making sure that there, you know, is kind of a even recovery across the city?
Yeah, well, I'm grateful that that the mayor has made this really central part of our overall efforts in COVID response. It's been very clear that, you know, one of our guiding principles has to be equity. And the reason is the one that you laid out. You know, anyone who's been paying attention for the last 12 months has borne witness to the fact that some people and some communities have suffered more than others. Particularly Black and Brown New Yorkers have borne the brunt of this pandemic with respect to the most severe outcomes, including deaths. And the reasons for that are complex. It is, you know, the historical patterns of injustice that have been laid down, not just in New York City, but, you know, around the country, intersecting with the devastating toll of the coronavirus more specifically. So those are the reasons that we feel so motivated to address equity. But looking forward, you know, and as part of our vaccination campaign, we have a chance to redress, you know, at least some of those inequities. We've been focused on age, race, and place as three of the key pillars of, you know, how we think about our own response to vaccine equity, particularly with, you know, focus on the task force neighborhoods in New York City, the task force on racial inclusion and equity, which carries forward the places that have been hardest hit and matches them up with, you know, greater resources, greater outreach, and a real, you know, dedication to trying to redress what we've seen in those places over the last year.
And you know, we're starting to run out of time, but I would be remiss if we didn't nerd out at least a little bit here. You know, there's some really amazing science that's been done, or at least had an opportunity to thrive during the pandemic, not least messenger RNA technology, which I think I could grossly simplify by just saying the Pfizer and Moderna vaccines basically, you know, it's kind of like putting your fingerprint into the bloodstream and it's telling your immune system, hey, kill anything that looks like this. And in which case, if I were the coronavirus, it would kill invasive Zacs. You know, now we're seeing this applied to malaria. And we've heard so much about how other technology being developed in the pandemic has great potential for making the world better than it was before. What are you excited about?
Yes, well, that is certainly true. You know, I'm really excited about the prospects of applying mRNA vaccine technology to other diseases. You mentioned malaria. There's some promising candidates to address HIV as well. And it is truly a remarkable thing when you step back and think about it. You know, if we were having this conversation a year ago and you had asked me, are we going to have 2 authorized mRNA vaccines with greater than 90 or 95% efficacy ready within a year, I would have said, you know, I really wish it were true, but I just don't think it's going to happen. And here we are with those amazing tools in our arsenal. But, you know, I'd be remiss as the health commissioner if I didn't point out that, you know, it's not just about those amazing technological developments. It's also about doing the things that are more bread and butter public health, which I think, you know, the layperson has appreciated much more over the past year. Building up our public health infrastructure, which spans everything from community health workers to our primary care colleagues, all of that infrastructure that really addresses both public health emergencies like the one that we're in right now, but also all of the slower moving disasters, whether it's chronic diseases or mental illness or thinking about substance use disorders. And we have a chance right now to unleash massive investment in those aspects of our response that will position us much better, not just for the next pandemic, which I hope is many decades in the future, but for all of those other things that we have to address that cause illness and suffering, even when we're not talking about a devastating virus.
So I think we got just over 90 seconds, but I want to make sure that we really leave our audience with some information they can use. We've all lived through this pandemic. We've all seen its toll on society in one form or another, and we all have a goal in our head. That moment when maybe 10 of our friends can all hang out at the bar, or we can go visit our parents, or go on a big trip across the world. How long do you think it is before we get to that point in New York City? And what are the steps we need to reach in order to get there in the meantime?
Great questions. I'll just shortly summarize it by saying there's what we can do as individuals, which is a lot, once you're fully vaccinated, which remember is not before 2 weeks after your last dose of vaccination. That opens up a lot of possibilities for people at the individual level. At the population level, it requires on us achieving certain goals. We've got to get to at least 5 million New Yorkers vaccinated by the end of June. I do think that will create some additional opportunities for us to get back to more of a semblance of normal. But I really think it's going to be in the fall or beyond, before things really feel different. And obviously with the proviso, as I said before, we've been humbled time and time again. So we've got to see how the new variants will factor into those timelines. But I have one thing that I would love to leave everyone with, which is we should all feel a lot of agency. This is not inexorable. This is not something that is just happening to us. We all have a responsibility. And the one thing that everyone can do, particularly if you've been vaccinated, is share your story. Encourage people who may be on the fence to get vaccinated and help answer their questions. We've got to create a snowball effect for vaccination in the coming weeks and months, because that's how we're going to outrun the virus.
Well, you all heard it all from the New York City Health Commissioner. There is hope, but it's going to take some vigilance, I think, is a pretty quick summary. Thank you so much, Commissioner. It's really been a pleasure hearing you speak today. I'm sure you're a very busy person.
Thanks for having me.
And I'll turn it back to Jeff, who will continue us in our wonderful program.
That's right. Thank you, Zach, and thank you, Commissioner. And well, gosh, I guess I gotta brag. I'm 1 dose down for vaccine, and I look forward to my second dose. So it really is quite a time of change and such a high pressure and also, frankly, interesting time for the New York City Health Department and for all of us who either work in health or politics or simply are interested. But of course, we're going to keep this conversation going. We have a fascinating next panel on prevention and protection for all New Yorkers. It is such a varying panel with so much to discuss. And with that, I would love to hand it over to my colleague, Kay Dervishi from City and State. Kay, take it away.
Thanks, Jeff. I'm very excited to start off our first panel of the day, Prevention and Protection for All New Yorkers. We'll be taking especially, specific focus on mental health, which, mental health needs have spiked significantly throughout the pandemic, and it'll be an important topic for us to be focusing on today. And just as a reminder for anyone who's, watching, please feel free to submit any questions that you'd like our panelists to answer in the Q&A function at the bottom of your screen. I'll try and take them as time permits. And with that, I'll start to introduce everyone who's joining us today. So the panelists who are participating in the first discussion are State Senator Gustavo Rivera, who chairs the Senate Health Committee, Commissioner Ann Sullivan, who leads the New York State Office of Mental Health, Commissioner Lorraine Cortes-Vazquez, who leads the New York City Department for the Aging, Susan Herman, the Director of the Mayor's Office of Thrive NYC, Susan Beane, the Executive Medical Director of Health First, and Charlotte Ostman, CEO of the Mental Health Association of Westchester. Thank you so much to all of you guys for joining us for today's discussion. With that, I'd love to start with a sort of broad question to sort of understand what in each of your positions you've been sort of encountering. And so, I'd love to hear more about how each of your respective agencies, organizations, et cetera, have, pivoted to respond to the growing mental health needs that have really been born out of the COVID-19 pandemic. And I'd love to first start with Commissioner Sullivan, if you could sort of give us a sense about, what the state has been doing at the current moment.
Thank you so much, and thank you so much for inviting me here today. It's a real pleasure to be here with all the panelists. There's two areas I'd like to talk about. The first one is prevention. And I think that this pandemic has taught us, or we know, for example, that up to 40 to 50% of New Yorkers are going to have some kind of mental health reaction to this pandemic. And some of it will be more serious than others. But how do you work with that volume of people to help them be able to cope with the aftermath of this and what's still going on in the pandemic? So we have a big project called Project Hope, which is funded through a FEMA grant, and it has 1,500 state crisis counselors across the state, and a social emotional helpline where people can call, anyone can call and talk to a crisis counselor any day of the week. And that line has so far had about 100,000 New Yorkers who have reached out, and we expect that to grow. And those crisis counselors provide what is really kind of preventive work, but if someone needs more help, they will then connect them to the mental health services that they need. The other area that's critical is schools. We all know that our youth have been really at a very different experience in school and at home, and working with schools is critically important. So the FEMA grant works with schools, but we also have, in this year's budget, we have $10 million that is going to a combination of working with state ed and OMH to provide special connections between mental health services and schools across the state in the high need areas. So it's so important to work preventively both with the public, but also with special target to schools and also to minority communities across the state. The FEMA grant is there. We also have some special suicide prevention work that we are doing in minority communities across the state. And then just another thing which has, I think, affected us all is this experience, telehealth and telemedicine. And that's something which has also shifted our field, enabled us, I think, to have more access, although there's still an issue with some people not having easy access to telemedicine, but more access and more availability for services. And we've seen that to be effective also during this pandemic. So that's just a couple of the things that we're doing to really deal with what we think will be an aftermath. And just to remember that many responses to this don't happen even during the pandemic. They can happen after, or even as things are getting better. So we still need to continue those preventive efforts on an ongoing basis.
Thank you for sharing that. And I'd love for any of the other panelists to jump in and tell us a bit more about how you guys have sort of pivoted your work trying to think about mental health during this time.
I will go next as the commissioner for one of the populations that has been the most affected by this pandemic, or has one of the early ones who have been affected by this pandemic. We had to balance between in-home supports as well as how do we continue to support those who were having independent lives and who engaged in our congregate settings. And so because the Department for the Aging is really about developing a community care kind of approach to services. So one of the first things that we did, particularly because social isolation has been a great focus of the Department for the Aging as a mental health issue, as well as a health issue that we have to address. So we immediately pivoted once the governor issued Matilda's law and the mayor issued Executive Order 100, which shut down all congregate services. We had to pivot from congregate services to virtual services with an eye towards social isolation, because these are individuals who chose to congregate with each other and socialize on a daily basis. And so we pivoted all of our work around social isolation to a virtual approach. And we engaged every agency as well as many volunteers to engage in what we called wellness checks. We first started out with making sure that where people were at and just doing regular wellness checks. We were doing up to about 70,000 wellness checks a week. We also had, because we have a strong geriatric mental health program supported by one of the panelists, and she'll be able to speak to that later, which is Thrive. Our geriatric mental health programs had to pivot the friendly visiting, which was an important component of our mental health services, to a virtual program. So we went and started doing all of our friendly visiting visits virtually. And I must say that they have worked quite well. The other thing that we pivoted, because we learned about these well-being calls, and we also learned from the experience of friendly visiting, the virtual friendly visiting, and the advantages of that, we then went to create something called Friendly Voices, which is a less intensive program than the friendly visiting program. But however, it has the same impact in that it is a great intervention for social isolation. And last summer, and again, we hope that we'll be able to do it again, we were able to launch a public service campaign with the voice of Lin-Manuel Miranda, who called all New Yorkers to be part of a wellness call and to make sure that to give 5 minutes of your time to an older New Yorker. And we were able to get many volunteers from that. So we have had to toggle between ensuring that we continue in-home services, but also how do we support people who had constantly been congregating and had very active lives, and how to keep them still engaged at some level. And then we pivoted not only the mental health services, but then all the recreational and educational programs to make sure that they were engaged. And they all have had some major impact on combating social isolation.
Susan, you look like you want to get in. I was going to
Yeah,
jump.
Hi, Susan.
Hi, Susan. Well, this Susan, for Health First, I would like to build on that concept of pivoting, and talk a little bit more about telehealth that Commissioner Sullivan raised, and the fact that we as managed care really had to provide a supportive structure for all of the pivoting that was going on. And frankly, it was pretty amazing to see our providers pivot from the usual face-to-face visit to use telehealth as a major means of staying connected with their patients and clients. And I really feel that among all of the providers, the mental health and behavioral health providers were extremely valiant about outreaching and ensuring that people, New Yorkers, stayed connected whenever possible. And this was really critical during the pandemic because obviously medication management had to happen. That was part of the prevention, even if you will, to make sure that those that were well controlled didn't lose that level of control and so on. From the Health First perspective, we had to pivot to be sure our member app was updated, could connect with telehealth to whatever capability, whatever extent possible. And I think the other big lesson learned here is that many patients really appreciated the telehealth context, meaning that it was comfortable for them. It was a way for them to stay connected with a provider, but to feel safe during the pandemic. For that reason, I think that there'll be some lessons learned from the pandemic, but one is that telehealth will not go away. And I'll be interested in what our other panelists feel about that. Finally, I want to cite and thank the Department for the Aging and their Community Care Link, because they were able to supply us with additional help for some of our members who became disconnected from the healthcare delivery system during the pandemic, doing outreach, engaging them, and through their own screening process, finding if there were New Yorkers who could benefit from some of the programs that were just described. I think we all had to learn to work together. That's one of my greatest lessons learned for the pandemic.
Can I maybe add just a few more ways that people pivoted? building on the extraordinary work that Lorraine and Susan have talked about, the adapting that we did in our Centers for Older New Yorkers, and the great sudden use of telemental health that really very few of us had been familiar with or using before. Thrive works with 13 city agencies and 200 community-based organizations. And our goal has always been to embed services where people are and when they need it in innovative ways. So we have a pretty strong network. And I want to just mention two other examples that you may not think about when you think about how people have pivoted. One is just a really simple but beautiful example. Our partner, the Red Hook Initiative, one of our partner organizations, decided that to continue to serve people safely who couldn't come to them anymore, they were just going to set up at a picnic table in a park in Red Hook, which they did, and basically sort of hung out a shingle that there was a social worker in the park. And I mention that because to me, it was a simple and beautiful way of saying, we're going to find a way for you to get to us, even if it's in the park that we know you're still walking around in. Another example that I was very excited about when I heard about it was health and hospitals began to see that their mobile crisis teams were not necessarily going out as frequently as they were before to do aftercare for people who had been hospitalized. And they thought, how can we repurpose them to serve another need that is really critical? And that need was bringing medication to people who might not otherwise have access to it, and administering medication. So it's a way of saying, you know, when you need to, how can you adapt, use the resources that you have, put them someplace else, or reimagine what you can do. I think we have lots of lessons that will go forward.
I just wanted to add and build on what everybody else already mentioned. Clearly, we all went from doing the bulk of our work in person to doing it virtually, and that was no different for Mental Health Association of Westchester. But some of the other things that we did is we had to bolster some areas of our services that people don't traditionally maybe think about us doing, and one of those is community education and support. We found ourselves a resource to schools, doing outreach to first responders and healthcare workers. Traditionally, populations that have not accessed us as a resource have come to us and really needed to get education and training, not only from our staff, but to train up and prepare their own staff to be able to recognize and respond to people who are having mental health issues. So that's something that was a shift for us. We also had to bolster our substance use disorder services. It's something that we have been doing for some time, but sadly there's been, after a big dent in opioid deaths and abuse, there was a quick upswing, and unfortunately many overdoses and relapses. So we have had to really put more resources in that direction. And of course, we did things as both the Susans mentioned and Commissioner Cortez. We had a food pantry, and since people couldn't come to us, we made our food pantry mobile. We used our staff and our vehicles to get out to people and do no contact deliveries, but do check-ins for people and make sure that people were well. So I think that, you know, people have had to innovate in ways that we never had before. And I think as we go forward, we're all going to be have to be resources for a larger group, for the entire population, because nobody has gone untouched from this.
Right. And I think everyone has already sort of touched on that broad idea of innovation, pivoting, and I definitely, we're going to talk a lot more about what that's sort of going to look like in a quote unquote post-pandemic future. But I'd love to go back to, Commissioner Sullivan sort of referenced the state budget and thinking a bit about what our legislators are also doing on the front of trying to, address mental health. Senator Rivera, could you speak a bit to what state legislature has been doing to make sure mental health needs are being supported in New York?
The first thing I'll say, well, thank you for having me here today. And the first thing I'll say is that I never mind playing second fiddle to all these amazing, talented women who are doing great work. So I will certainly take a backseat to all of them and say thank you for all the work that you've done in all of your agencies and all your entities around the state and the city. For me, I'll just say quickly that, one of the things that, we had to deal with the same issue. My office has remained open virtually for this entire time. And we were dealing with a very high needs district that obviously was impacted economically. It was impacted health-wise. In some of the height of the pandemic, some of the zip codes that had the highest rates of hospitalization deaths were in my district. And obviously the impact that the economic instability, the health issues had on the mental health of my constituency was something that we tried to deal with, and we had to deal with virtually as best that we could. So that means connecting them to many of the agencies that you've heard speaking today. As far as what are some of the things that we did, I'll speak quickly on what happened in the budget. It is, I've been in the legislature for 11 years, and I'm still surprised, I got to be honest with you, about everything that we were able to achieve in this budget. With the recognition that there's still much to do, but we were able to do so much, not only in the big scheme of things, whether it was taxing the wealthy, getting record education funding, the excluded workers fund, as it relates specifically to mental health. We were able to restore 5% cut that the governor had proposed to the mental health budget, and that it was clear that we needed to reject the austerity that has been baked into budgets for quite a while. And we also included a 1% cost of living adjustment for mental health and substance abuse workers, which is something that these individuals who do some of the hardest work in the health field have not received in 12 years. And particularly during these times when you have high rates of substance abuse and mental health crises during the pandemic. But there's still much to do. And I would say that my pitch for the rest of the session, as we took, I took like a day off, and that's it. Now back to work, and there's much to do in the final end of the session. And one thing that I will say related to mental health, as well as to other health issues in the state of New York, that is the reason why I'm fighting so hard to pass the New York Health Act in the state of New York, which is a bill that would guarantee healthcare to every single New Yorker, including comprehensive mental health services. I believe that not only we need to make mental health a priority, but we need to make the idea that health is a human right, and having access to healthcare is a human right, including comprehensive mental health services. We need to make that a reality. So I believe that the New York Health Act can do this, and we'll continue to work the rest of the session to make that a reality.
Thank you for sharing that, Senator. And definitely you've sort of raised a good point in thinking about what we need to think about post-pandemic, what's going on in the future, and definitely we're gonna have some more robust conversation about what else needs to be done. I did sort of wanted to loop back to the idea we talked about all these different innovations, people have had to make during this year to make sure that, people were getting needed services despite everything going on. I wanted to ask what you all have sort of taken away as significant lessons from the past several months as far as, best practices for addressing mental health challenges. I know we sort of mentioned telehealth is sort of a key piece of that as well. I'd love to send this over to you, Charlotte, to respond to first. What are sort of the key things you've taken away?
So I think I'd like to talk about two things. The first is that despite the fact that we were primarily delivering services virtually, we, unlike much of the business that takes place in the world today, are not dealing with marketing or selling products. We're dealing with human beings. And at the end of the day, there are times that people have to have face-to-face contact, just like in other healthcare situations. Our clients need injections, they need blood work, And some people simply do not have the resources to be able to have contact virtually. And so that means that people have to go out in person and be seen, whether they're homeless, couch surfing, or otherwise unable to access smartphones or other types of technology. And so it's been important for us, while we are doing as much as we can remotely, to keep in mind that there has to be a balance. And I think this is something that we have to use to inform our practice going forward, that we have to have a hybrid model. It's not enough to just see people individually. It's not enough to see people virtually. It has to be some mix of seeing people in person. And we've used a risk assessment, a stratification to determine who needs to be seen. There are populations that we serve, people who are in foster care, domestic violence situations, many kinds of situations that people really need person-to-person outreach. And when people are really in crisis and need to be assessed, that really can't be done remotely in some cases. So knowing that there is no 100% virtual option, that's certainly a lesson learned. And I think the other most important is about taking care of our staff. Our staff has experienced, just like many others in healthcare, extreme vicarious trauma, dealing with death and loss of all sorts, social loss, and really just hearing stories and not being able to mourn traditionally. I could go on and on about the substance use things. We've had many deaths of people that aren't related to suicide, but because people have comorbid health conditions that are not being addressed properly because they're not able to access healthcare or because the traditional supports are not in place. And so all of those things are tremendously affecting our staff. We have a, by and large, female-dominated workforce, and women have had to leave in droves our workforce because they have to care for their children. They've lost school, they have to homeschool. There are stressors all in every direction that make it difficult for them to manage their households. So thinking about those things and being as flexible and supportive as we can, and giving our staff the resources that they need to maintain productivity and their own health and safety has been something that we recognize. And we think that, organizations universally in the United States are going to need to recognize going forward.
For other panelists, what other sort of big takeaways do you think you guys have seen just from the past several months, as far as, needed lessons that we need to sort of carry forward with us before we sort of begin thinking about what's next after the pandemic?
Just to add that one of the things we've learned from our helpline is people call in with who've never contacted mental health for any reason before, call with all kinds of questions like, how do I talk with my child about the pandemic? Or I know my husband's worried because I'm in a position where I could catch the virus, but I don't know how to talk to him about it. Or I'm worried about my family, or I'm feeling socially isolated. I think it brings forward the fact that so often we don't know how to help people deal with those. Those same things can come up with a crisis every single day. It's not unique to the pandemic. And we have to be out there. I think what we've learned is you have to be out there more in a preventive way that offers wellness and helps people know how to deal with these issues in their daily lives, because that's how you prevent some of the sequelae of more serious mental illness. So I think it's taught us as an agency that move towards prevention, wellness, social people getting together and knowing how to support each other, that we have to do more work in that area, because people clearly needed that help during this, but this is just one crisis that happens in our lives, and there are many others that can come up. So I think that's a lesson learned in terms of public health, and what's really important in terms of getting the message out there about overall health and wellness.
I was going to add to that. Thank you. That's a great lead-in, because I think one of the lessons learned for us was the need to expand community services. for older adults, including community mental health services. But we also know that older adults, studies have shown over and over again that older adults' mental health and health, physical health, improve when they are in community services with supports rather than institutionalized. And so we also saw the devastating effect that this pandemic had on nursing homes, not only on the individuals and the number of deaths, but also on the families and the isolation that caused. So that leads us to really come up with a robust plan for having community support so that people can age in place as long as possible with dignity and have the supports necessary to do that and avoid institutionalization or nursing homes where possible. We know that there's some populations that will need nursing homes and those should be available for them. But to the extent that we can build a robust community care plan where people can age in place, that has been one of the lessons learned. And we're very fortunate that this mayor has now made a $58 million investment to do just that, to expand community care so people can age in place with the proper supports. And that is an important feature for us moving forward. I think New York will serve as a model for that. And this is also beyond just Medicaid eligible. We have a very robust long-term care program for the Medicaid eligible, but many older New Yorkers are not Medicaid eligible. So this goes beyond that.
And I guess, I just sort of want to highlight one piece that Charlotte in particular had sort of talked about, which is the what sort of reliance we might be using telehealth in the future. There's obviously a lot of benefits that you all sort of highlighted, but obviously, there's been a lot of concerns that, there's not always as much privacy trying to do it from home. Not everyone always has that equitable access to technology. And I did sort of want to dig into a bit of how you sort of see telehealth playing a role in mental health care in the future. And I'd love to start with you, Susan Beane. I know you sort of looked like you wanted to address some of the other things too, so.
Sure, that actually was, that is a topic that's really top of mind for me, and that Health First. I think that we have done as many other managed care organizations in terms of trying to understand which ones of our members, which populations of our members have access to the technology, understand the technology, and actually use the technology that would keep them connected to the healthcare delivery system. And there are many options for behavioral health and mental health providers in the telemedicine world. But the real challenge is, and the takeaway that we have is that there is not enough access. And so, there are all kinds of smartphones and tablets, et cetera. New York City has done a lot to expand the access to these devices and Wi-Fi access and so on. But this is going to be part of that hybrid model that was mentioned before going forward. And so at Health First, we are really exploring ways to put smart devices, if you will, in the hands of people, but not just in their hands with whatever they need to stay connected. Smartphones are only one solution. We are looking at ways to provide smartphones to some of our members. We're trying to find ways to collaborate with agencies that are already doing hard work in certain sections of the city so that we're not duplicating. And we're also understanding how we can invest in helping our members use these devices. And I'm sure that others on the panel will sort of speak to that as well. I know that was a budget consideration, Senator Rivera as well, in terms of technology access. So, I think that equity is the sort of underlying thread here that we have to speak about in all the populations that have been affected by the pandemic, and we all have, but especially in some of the communities where the use of smart devices, if you will, is not readily available and is often life changing if they can actually have access.
I can jump in, and because I think that's a great segue to just saying there's no question that one of the lessons from this crisis is that historic inequities have been exacerbated. It's not that these inequities were created by this pandemic, they've been exacerbated. And whether that's access to the internet, or it's access to providers, or being able to deal with linguistic or geographic or cultural barriers to healthcare, it's all gotten worse. And it's all been shown to us in stark relief. So in my view, I think the investment in bringing the internet to more parts of New York City that we've now committed to, 200,000 more people who live in NYCHA developments are going to have access to the internet soon. Bringing cell phones to people, saying you now have service, here's a cell phone, you now have service. If it's covered by Medicaid and they're covered by Medicaid, terrific. If not, we need to be able to provide that to people. But because of these inequities, we need to keep focusing on historically underserved communities, historically underserved groups of people, and making sure that what we've seen, which is that people turn to the people they already trust, that those people, those institutions, whether it's faith leaders or local social service organizations or their primary care provider or a mental health clinic, whoever it is they trust, is able to provide mental health support or get them to the support that they need. We've seen, as I think Ann mentioned earlier, people are calling about a wider range of issues than they were before, whether it's mental health issues or they're asking their clinician about how to deal with their housing problem or their food insecurity. So we all need to realize that we are one social service and health safety net, and we need to keep it strong so that all of us can respond to people appropriately and help people get to the service that they need.
And one quick, if I could add just one quick, very quickly.
Okay, sure.
There was something that we passed in the budget related to, particularly considering that we need to serve our communities that are most vulnerable. And we've passed eligibility for households that receive free or reduced price lunch through National School Lunch Program is eligible for to receive SNAP or Medicaid, SCREE or DREE. They receive an affordability benefit from a utility because we understand how important high-speed internet is to every single New Yorker, whether they be low-income consumers or not. Sorry to interrupt. Just wanted to mention.
No, I just wanted to ask Dr. Beane to talk about a project that we're working on together, which I think it's exceptional, bringing exactly what Susan said, bringing together community services, community-based services, and health and mental health services. So you want to take it over, Dr. Beane?
Sure. I'm glad to mention this collaboration because we have to start thinking about health differently. We have to stop thinking about health as what happens in the doctor's offices. I'm speaking to the choir here, but even social risks are intertwined with medical outcomes. And we found that if we could identify great partners in the community, we could together reach some of our members who are most at risk of falling away from the healthcare delivery system completely and or becoming victim to their social risk. So we asked the Community Care Link agencies, which are some of the important community agencies serving our aging population in New York City, to be our helpers here, to actually be the workers, to outreach our members. And together we're determining what changes if we do that. So number one, I'll say that, a lesson learned is that people disconnected from care. Even as I praise the mental health system, behavioral health system, people frankly did disconnect from care. And Department for the Aging, through the CCL, Community Care Link agencies, has been outreaching our members and finding them. And every member found is like a jewel, in terms of our being able to reconnect them. But most importantly, our early finding is that the collaboration with this historically social agency actually promotes healthcare prevention. And what that means to us is that New Yorkers will get back into the realm of looking after themselves, not only their acute needs, but also their ongoing health needs as well. And these agencies are very proactive about connecting our members who are New Yorkers to mental health services. So I just hold it up as a model to say that